Assalamu alaikum everyone. I'm Dr. Hamza Abdul Malik and my moderator Sayyid Rafiuddin Shah. And today I am present the topic which is principle of PET imaging and the molecular imaging, generative malignancy. So our objective of the day is to understand the basic scientific principle of PET CT and appreciate the clinical role of PET CT in patient investigation and the treatment and the basic interpretation of commonly performed procedures. So, start from the definition. So, what is the nuclear medicine? Nuclear medicine is the branch of radiology specialty that uses radioactive tracer to assess the body function and to diagnose and treat the disease. So, here in this picture is the summary of this presentation, which is the nuclear medicine in which the patient is the source of radiation, and in the CT and the X-ray, the external machine is the source of radiation. So there is a basic difference between the nuclear medicine and the conventional X-rays and CT and MRI.
Yeah, he's saying that in nuclear medicine, what happened, we inject the radiopharmaceutical. If a source of radiation is in the form injection, we inject that a particular radiopharmaceutical which is distributed throughout the body, and there is emission of radiation through the patient, which is recorded by the gamma camera in two routine nuclear medicine cases, and in the PET scan, which is recorded by the PET camera.
Yes, thank you, sir. So it's the invention of the year in 2000, the PET scan. So history is that in 1978, this first commercial PET scan was introduced, and in the 17th and 18th century, PET was mainly used for the research. In 90, it started for the clinical practice and the first approval in 1998. So introduction of the PET scan, the positron emission tomography is the combination of physics, chemistry, physiology, and the medicine united in an effort to measure the physiological parameter non-invasively. And the PET and the MRI is the combination of functional image as anatomical images. So here in this picture, you see the first is the anatomical image, then the PET scan is the biological image, and the third image is the hybrid image which show the both PET CT. So PET measures the biological process and the CT generates the high resolution cross-sectional images of the body anatomy to combine of the both set of the information to identify the patient disease in early stage. And the combination of the PET scan is, if we perform it separately, it give not better result, and when we can perform combine, it gives a good result. So how to get the PET image? So the basic physiology is saying with the cell and the atom have an electron, and the cell inside the cell have a neutron and the proton, and the outside is the electron. So different nuclides and the isotope have the stability and the unstable, which is present in the cell, and the other which we introduce in the body is the unstable. So nuclides is a different arrangement of the nucleus. If the arrangement is unstable, it is radionuclide. And otherwise the isotope, the element have the several isotopes. All isotope elements have the same atomic numbers and the different neutron number and the different mass number. And the unstable ones generally called radioisotope. So in this diagram, you will see there is a one cell is stable, in which there is a 3 proton and the 2 neutron. When this unstable stable cell combined with the unstable cell, this is the one for the stabilization of this cell. There is a proton emit to the unstable cell, and when this emit to the unstable cell, it emit the rays. There is the alpha rays and the beta rays and the gamma rays. These all three rays and for use for the function. But now we use the gamma images emission is the best for the imaging.
इसको थोड़ा आसान कराएं सर से. Easy. If anything,
If
confusion, then anybody can ask the question. But I think it is basic physics, right? समझ में आया भाई सबको? ठीक है, फिर पीछे चलेंगे।
is mean by functional images and CT? ये सेम मशीन पे हम दोनों कंबाइन कर लेते हैं या अलग अलग मशीन होते हैं?
They are different machine. Actually, if you have seen the machine, we have a two categories. First patient is a scan, CT scan, and we take the whole body image. And after that patient, there is another imaging, which is called PET imaging. Patient goes again into the gantry of the PET scan and we take the whole body PET images. So these are double image, two different modalities, and we combine the images of CT scan and the PET scan. PET scan images are similar to like that of you can see in the nuclear medicine, like bone scan or other renal scan like that, black and white. When we combine, then you can see that if anything abnormal in the structure, suppose if there is a lungs or lung and the kidney and any lymph node which is abnormal, looking appears to be abnormal in CT images, that is investigated on PET image, and it shows the metabolic activity on that abnormal tissue. So we'll see in the image in the.
Yeah. So again, this is showing the basic principle of the PET. Is as we discussed, there is a unstable for the stabilization of the cell. There is a proton is released, and then it's released and it's combined to the outside of the electrons. And when it's combined to the electron, annihilation of the positron and the electron, and it emits the rays, which is the gamma rays, and we discussed before the gamma rays, alpha rays, and the beta rays. Here we discuss the gamma rays, emit the gamma rays in the opposite direction. And in the 1000 or the 1000 second, there is a multiple rays emit, and it's detected by the PET ring, and it create the biological image. And with combined with the CT, we give the anatomical image and the hybrid image. So production of the nuclides, and there is a many of the nuclides we use, and mostly we use in the fluorine 18, which is half-life is on 110 minutes. Why we use F18 FDG? It's a natural compound, mostly used glucose analog. 2-fluoro-2-deoxy D-glucose FDG. Because of its small size, its addition to a molecule, and it's never harm to the body. It's anywhere else been going without if not take any part of the body. It's the glucose. It cannot harm. Its half-life is 110 minutes. Is long enough to perform complicated chemistry to allow the transport over the some distance. It also long enough to keep the radiation burden in the patient low, and the image is biodistribution of the sugar in the body. Here is the half-life of the radionuclides. You see the other half radionuclides, the half-life is very short, but in the FDG, fluorine 18, is the half-life is approx 110 minutes, which is enough for the performing the scan. So that's why we mostly use this FDG. So how this FDGs work? As a cancer cell have a receptor, which is a glucose transport 1 receptor. When the glucose and the combined with the F18 is the isoreceptor on this receptor glucose transport 1, and which is enter in the cancer cell, and which cannot further metabolize due to the deficiency of 2-hydroxyl enzyme, and it remain in the cancer cell and emit the gamma rays as we discussed before, and this gamma rays is detected by the PET ring, and we get the image which is the seen on your screen is the hybrid image. This is showing the high metabolic areas like normal areas like the brain. Excuse me. Like you see brain, heart, and somehow in liver. Other by highlight areas and the light areas showing the abnormality, which is not commonly present in the high metabolic areas normally. So what are the indication of PET imaging for the staging of the cancer and the baseline staging before the commencing the treatment, and they characterize the indeterminate lesions to assess the response of therapy, to assess the suspected disease, recurrence and relapse, and the residual disease. It's also helped to target the biopsy. If you show in the picture, if you target the biopsy in the cold areas, there is they have a chance of a fall result. But if you get a biopsy from the light areas, and the uptake areas and the high areas, so it's a chance of the good result. So it's also the problem solving when we confuse in the metastatic or non-metastatic disease for the evaluation of the recurrence in the patient with the negative equivalent conventional images on the CTI MRI, suspected malignant transformation, difference between the radiation-induced necrosis and the tumor recurrence and the detection of the source and the inflammation also. So how to perform the PET scan? So PET scan start from the after the prescribed from the onco physician who pre-op instructions give the chart by the our institute to prepare the patient to the test was before the test we did not take anything at least 5 hours and it take water good hydration take less protein diet because it gave fall result and your sugar is less than 130 milligram and not take any supplement and the vitamins it also gives the fall result and the others things more like don't give any hard work like if some technician says that we give instruction to the patient not come on the bike because of the due to the muscles working it's release the glucose and give him the false result, maybe false result. Sir, you can add some instruction or otherwise?
Yeah, you have already explained all the things. If any question,
So throw some lights on the precautionary prerequisites of PET scan. Which
actually what happened, the FDG, which he will explain, is an analog of glucose. So when we inject FDG, it behaves like a glucose molecule in the body. So we advise the patient to take proper rest 24 hours before the examination. If the patient do some street work or commute by motorcycle or rickshaw, what happened? All the muscles are very active because they need glucose. So when we inject the FDG, that in FDG will go to the muscle. So what happened? The in the body, the adequate amount of FDG not removed for the tumor tissue. So we want to keep the muscle in relaxed position, so they don't need any extra glucose. If the muscles are in a situation, they would happen, they engulf all the FDG molecule. So short of we will be able to highlight the tumor tissue, right? Anything else?
Thanks. So before start the procedure, we calculate the dose of the patient according to the weight of the FDG. Here we show on the left side is the Galenium 68 machine for the prostate cancer and for the endocrine tumors. And on the right side, there is a calculator machine for the FDG. The maximum dose is this 10 mics and the minimum dose is 5. After injecting the dose, there is a shield of lead shield which is present and the technician or the instructor the stand on the behind the screen and inject the radio tracer behind the screen and which show here is a lead cover which cover the already syringe to save the technician for the radioactive molecules also. After injecting the isotopes, wait for in a waiting room at 50 to 1 hour and then go for the procedure for the PET scan. After PET scan, again come in the waiting room and wait for the 20 minutes to see the picture if all is okay, and then end the procedure and give the some instruction. Because of the, we know the FDG is half-life is 110 minutes, but it still remain and the patient has a charged particle. So we give the instruction to avoid to keep the distance from the child and the pregnant ladies, and with the good hydrations.
ये जो आखिरी वाला है इसमें कितने घंटे
So for this, at least 24 hours for ask the patient keep
Right.
24 hours.
It is actually FDG has a half-life of 110 minutes, right?
Hmm.
So usually most of the FDG clear out within 2 to 3 hours. But for safety reason, we give a wider range, so it's 24 hours.
24.
It's the best time.
ये डैश खाली छोड़ने के लिए देते हैं डिफरेंट है
Different.
Actually,
तो पेशेंट है
पता नहीं क्यों खाली छोड़ा, मैं तो 24 आवर ही कहता हूँ सबको.
It's our performance. Okay. So, role of the PET scan in the genitourinary cancer, it's a detection of the metastasis in the early stage in comparison of CT and MRI. Although the guideline is the same, which is not preferred, then there is a much initial indication of the PET scan. Here we've seen in the, also we've seen in our tumor boards and other things, we also advise PET scan in our last resort. Because of the, we see the good image on the CT urogram and CT triphasic. And after discussion, if need any patient, then we prescribe the PET scan. Here is some result of the articles. They show the good sensitivity and specificity of the PET scan in comparison of CT and MRI. But the still is the CT and MRI is more important than PET. It is some images of the PET scan which show the abnormalities. It is the first picture. I think our average result is easily identified because we see in a tumor board meeting this type of image because of there is the lesion in the bone with the marker company. Here you see the CA prostate with the bony mets. Sir, आप थोड़ा सा अच्छा explain कर सके.
Actually, I think this is the PSMA scan, right?
Yes, sir.
PSMA scan. Yeah, and you can.
Yes, sir. Yeah, pointed as well.
So this is the bladder you can see, and in the base of the bladder, I think it is not well highlighted here. It might. So there is a uptake in the prostate, right?
Yes.
This is the prostatic tumor with secondaries, multiple secondary lesion in the iliac bone, in the vertebral spine, and yes. So, but there is no lymph node in the area, right? So, prostate cancer is affected bone. Mostly metastasis to the bony tissue. So here we can see this is stage 4 disease.
Yes, sir. And another image for the left side renal mass is actually the patient has a history of left nephrectomy, and then for the residual mass would it PET scan. So we see in the first image and the third and the hybrid image and the last this or this the renal mass residual mass in the renal bed with the lung mets.
This is the post-nephrectomy images follow-up for the residual tumor, and you can see this is the nephrectomy side, and you can see there is extra soft tissue here, and definitely something CT scan that is also advised for the PET scan, and in PET scan we can see there is an increased metabolic activity. And extra tissue, this site should be clean. There should be no extra tissue after nephrectomy. You know what happens? The site is and no extra tissue in the paravertebral region. But this paravertebral soft tissue element is the recurrent mass, which increase metabolic activity, and you can see the soft tissue nodule in the lung as well. So this is in favor of metastasis. One thing more that I want to say that the metabolic activity is considered to be abnormal. Cutoff value is 2.5. If anything, any soft tissue, any abnormal tissue, or any side of the body, if there is increased metabolic activity of more than 2.5 SUV, this is abnormal, and below that it is considered to be normal, right? Yeah, definitely there are different rules, different, because if usually the inflammatory disease are radiologically very evident. Suppose in the lungs, if you have inflammation, you can see the consolidation. Consolidation involve the specific segment of the lung, or in a specific layer of the lung, well defined. They respect the and fissure and the segments. But malignant tissue, they does not respect that segment. They invade the soft tissue as well, and they have the soft tissue density. Whereas in the inflammation, if there is suppose a consolidation in the lung, the density will be like a dirty fluid density, like a 20 or 30 or like that. Whereas if there is any soft tissue mass, the density will be more than 50, 60, right? It will be soft tissue. And inflammatory tissue will have the fluid density. And on the other hand, if there is a malignant tissue, malignant mass or malignant lesion in the lung, it shows the high metabolic activity. Inflammatory lesions usually have the metabolic activity like 2.5, 2.7, 2.8, 3, like that. And in the tumor tissue, metabolic activity is more. And if there is area of necrosis, you can see more activity or photon deficient, photon deficient area due to necrosis, because there is no blood supply, no activity. So there are different ways to differentiate clinical presentation, history, and all that as well. Yeah, so and what happened, we advise the patient to go for PET scan immediately after this procedure, because at that time, immediately after surgery for 2 weeks, there is inflammation and there is increased blood supply, hyperemia, that may also give to the abdominal uptake in the area and give a false impression of the residual disease. So usually we advise to do the scan after 2 to 3 weeks. So it's very clear on that PET scan.
Thank you. One more picture for the bilateral renal mass. Give that.
So you can see the mass, and this mass is highlighted in this is the CT scan and this is the PET scan. You can see the increased metabolic activity. Right? The right side mass is not small lesion here, right? Very small lesion here. This is you can see the black area is the fluid, which is, and in the you can see there's a white area, that's a very small soft tissue element which is highlighted here, right? Left side is I think in the right side also there is mass in the renal pylorus collecting system. And
एक colon की side जो है C
there is another soft tissue nodule here. You can see this, they highlighted here. This might be a metabolic deposit.
right ureter uptake in the PET CT.
ये क्या था ये?
सर राइट यूरेटर के अंदर जो है वो यूरेथ्रिक कार्सिनोमा है, राइट यूरेटर
अच्छा, यह राइट यूरेटर में क्या था?
विद कार्सिनोमा,
अच्छा, कार्सिनोमा था राइट यूरेटर का
with the lymph.
So this is the mass actually highlighted. I think you should have yeah, this is the corresponding image. Corresponding of the image of the CT is not there. See, this is these are the two different cut of the CT. If this is the mass, we should have the CT scan. I think this is the mass of the vista ureter, which is highlighted here, associated with lymph node as well. This is the hyper metabolic mass region here. and this is highlighted. But usually what happens is this type of picture you cannot say this is mass, because usually the urine are the hypermetabolic FDG loaded urine, when you are loaded urine and pass the liver, sometimes it causes some degree of history, and this is highlighted. So on this image we cannot see. We have to compare this PET image with the corresponding CT scan, and if there is any soft tissue element and this uptake, then it's possibility of the tumor or the lesion in the ureter.
See a bladder with the diverticulum.
This mass is high metabolic, right? You can see on the CT scan, and this is the urine, this high density is urine. No, this is also bladder. Yeah. This one is this black area. In the blood, all issue. DG.
Again, the right, left renal mass, which show the uptake. Yes, sir. Mention on. Or is yes, sir. Sorry, sir. This.
This is um, is the corresponding this one. But this mass is not highlighted. You can see this is not highlighted in Panda scan. This is the mass. This is the mass. And one thing more that I wanted to explain, that FDG PET scan is not required for the urinary tract malignancy. Usually, it is not advisable for the diagnosis, because in the kidney, in the bladder, we have already urine concentration which is loaded with FDG.
Mm.
So it camouflages the tumor tissue. So it is not indicated for the urinary tract malignancies to go for the PET scan. Only indication if there is a suspicion of any secondary lesion, like suppose renal cell carcinoma associated with some lung nodule, which was not present at the time of presentation in the early phase, but later on follow-up, you find something abnormal in the lung, some soft tissue nodule or thing, and then you want to differentiate whether it is a malignant or it is a secondary lesion or it is not. Or if sometime if there is a kidney tumor associated with backache or pain, and you find the lytic lesion on X-ray, then you need to confirm whether it is a malignant or benign lesion. So then we go for the PET scan. Otherwise, concentration of FDG in the kidney is not well highlighted. Similarly, in the bladder, is the for the diagnosis of bladder malignancy, best is the cystoscopy, right? So on cystoscopy, you can see yourself very easily if there is any bladder wall thickening. A CT scan and MRI give you information about the surrounding area outside the bladder, if there is any lymph node or anything like that. But actually, for the primary, if the patient present with the hematuria, best is the cystoscopy. On cystoscopy, you find anything abnormal in the wall of the bladder, you take the biopsy, and after that, you go for the staging CT. On staging CT, you find lymph node, area or in the vital area, then there is indication of the FDG PET scan to rule out whether these peripheral lymph node or the perivital lymph node are malignant or the benign.
That case, PET was not indicated.
For diagnosis, no, it's not. It's,
से पूछा है तो शक्कर वालों को सवाल करो।
Any question from Sakkar side?
सवाल है क्या?
Sir, is there any difference between the mechanism of FDG PET and PSMA PET scan?
yeah, these are two different identities actually. PET is actually not a imaging. Imaging is actually, PET is like a gamma camera, right? And the imaging is depend upon the pharmaceutical. As you like the bone scan, renal scan, you can see difference, right? Renal scan by MAC3, bone scan by MDP, right? Two different imaging. You see, similarly, for prostate, we use totally different pharmaceutical, which is PSMA, prostate specific membrane antibodies, right? So what happened in the prostate cancer? Uh, Usually the prostate has a membrane antibody and antigen, and but in the tumor tissue, what happened? It become more exposed to the surface of the tumor, and it bind the antibodies. So when we gallium gallium is a source of um, photon. um, PSMA is the antibody, prostate specific antibody. It is a tracer. So when we combine the gallium as a highlighter or as a source of light or the source of photon, what happened? We inject the gallium PSMA or F18 PSMA. We also do the F18. F18 also use in this prostate study. So it goes it circulates through the bladder, and it is taken up by the all abnormal malignant prostate lesion, any lymph node or any mass. If the mostly we have the prostate secondaries in the bone and in the pelvic lymph node, right? So it is taken up by that lymph nodes and the um, secondaries in the bone and highlighted the before that PSMA is imaging. It is really difficult to highlight the recurrent prostate tumor. No imaging can give you the information about the recurrent tumor after total prostatectomy or surgery, right? Because on MRI it appears very late, and in MRI and the CT scan, the criteria is if any lymph node is more than 1 centimeter, they consider it to be abnormal, right? But with the advent of this PET scan, what happened? If even if the secondary lesion or recurrent lesion is less than centimeter, it is sub-centimeter. But if it is PSMA would, it means there is a recurrent lymph node like that, right?
So I have a question. Why would PET not done in an overweight patient? As you mentioned in the performa, if the weight is more than one, I think 18 likha. So
Because machine does not bear this weight. This is for MRI, CT scan, and all. Pretty much all.
okay.
Uh,
It's not a matlab, case of isotopes or make it.
No, it's not
Yes, it-
normal.
So the key point of this presentation, PET scan is a combination of functional image and the as well the anatomical image. Nuclear medicine is the patient is a source of radiation, and in CT is the external machine is a source of radiation. Mostly we use the FDG for the isotope, and for the generative malignancy we use FDG with the various of the degree for the technique and the anatomical images. But the sir said there is no use. We use PET scan. Initially, we not use as a use PET scan for the imaging. After CT and MRI, then there is a need of any extra image and there is a specification of the lesion. Then we use FDG excretory in the urine. So we use as a FDG tracer for the distant metastasis. And for the prostate, we use 68 gallium for the prostate imaging to localize the prostate cancer cells. Thank you.